Hi, so this is chapter 7, Barbara Garcia, and we're going to talk a little bit about neoplasia. And basically, when you think of the word neoplasia, you probably think of the word cancer, right? Because neoplasia means growth, right? So plasia means growth, neo means new. So this is some sort of new type of growth, usually implying some sort of tumor growth. And so remember, when you think of cancer, you want to think that cancer can be either benign or malignant. A benign tumor is a tumor that usually is encapsulated by some sort of connective tissue, so it doesn't spread. However, that does not mean that a benign growth can't be life-threatening. Because if you had a large tumor that crushed your colon, for example, that then prevented you from doing normal function, then it really could be very life-threatening. All right, so malignant usually implies that there is no type of connective tissue that's surrounding that tumor, and thus cancer cells can then migrate. And the way they do that usually is through lymphatic tissue. This is why we test for our lymph nodes to see if there is metastasis or spread of cancer cells throughout the body. All right, so malignant cancer, I mean, once you have cancer cells established in different areas of your body, obviously it definitely increases the likelihood of death, right? So of it being fatal, right? So malignant cancers may not be survivable. And then cancer, of course, is associated with some genes that have been modified somehow. And remember, we can modify genes with many different types of introduction of either toxic chemicals or of UV radiation or things that are not anticipated to be in the body. So those things are like an attack, and in response, sometimes you'll see changes at the genetic level, which could cause cancer. All right, so so a malignant tumor, right, can and most likely will kill the host if left untreated, right? It is usually invasive and or metastasizing. So remember, the word metastasis means that it's moved from one area where it was originally located into other areas, right? And then you might see also tissue specific differentiation, so that the actual tissue that is growing is not the same in an original tissue that was there, right? So we call that anaplasia, right? So the growth of tissue that does not resemble the actual tissue type is going to indicate a lot of or great and aggressive malignancy, right? So malignant tumors grow very quickly. One of the things that you might see with tumors, and often are a target of treatments for tumors, is angiogenesis. So angio means vessel and genesis means creation of. So a tumor requires significant amount of nutrients, right? Because it is growing, it is undergoing mitosis very quickly. So because it is going cell cycle through cell cycle through cell cycle, they're very demanding of nutrients. So they require lots of blood in order to get those nutrients. So one of the things you'll see is angiogenesis occur. So in a treatment for cancer, why don't we stop the angiogenesis? Why don't we stop that new growth of blood vessels, so we starve the tumor? And when you do that, you can have maybe a reduction in the size of a tumor. So if a tumor is large, we can reduce the size so it's easier for it to be removed, so it's more operable. Your malignant tumors are often necrotic as well, and they do not indicate that they are cells that are functioning in the same way that the cells that are originally there. So in other words, those cells are non-functional cells. So even though they're there, they're basically just they're growing, not contributing to the function of that organ. All right, so for example, here you could see cells that are normal cells, like you might see, cheek cells look like this. Your cervical cells look exactly like this. But when they become anaplastic, they're going to then change their shape, and you might see a increase in the size of their nucleus, decrease in the cytoplasm, and so there's visible changes that you're going to see and in the tissue and the tissue type. Now, benign tumors, right, does not have the potential to kill the host, but may be life-threatening depending on its location, right? Like I mentioned before, most of them are encapsulated. right? So benign tumors often resemble original type of tissue, right? So they might even retain the original function. So have you heard of a pituitary adenoma? So if we had a pituitary adenoma that secretes growth hormone, what is going to result, right? In a child with epiphyseal growth plates that are still open, this child with a pituitary adenoma, that is a benign tumor in the pituitary gland that is still with functional cells that secretes growth hormone, they're going to have an increase in growth hormone. And so they're going to get very, very tall, right? So you're going to see that result in something called gigantism. Now, if that same tumor were in an adult with epiphyseal growth plates that are closed, right? So they have epiphyseal lines, then that adult will have something called acromegaly, right? So you might also see them called acromegalic gigantism, and then just acromegaly for the adult version of that pituitary adenoma. Just to give you a little idea, by the way, you can have pituitary adenomas, which are all benign tumors of any one of the hormones that the pituitary gland makes. So you can see a prolactinoma, right, would secrete prolactin. All right. Little vascularity, rarely necrotic. And again, they often can have that original tissue and still can function. Right. So benign tumors and malignant tumors, and a little bit on their histology, right? Their growth rate, location, and tumor necrosis, recurrence after treatment, and prognosis. So this is a really good table to kind of just give you that idea of what we're talking about between benign and malignant. So if I had to ask you, compare and contrast benign and malignant tumors, this is going to be a good place for you to be able to do that. All right, so terminology. OMA usually refers to something being a benign tumor. However, there are things like lymphoma that is not necessarily going to fall under that. So you might see, again, a pituitary adenoma. They are going to be benign tumors. If you see carcinoma or sarcoma, those are different types of tissue origin, right? So for an example, carcinoma is epithelial in origin. Sarcoma is mesenchymal, so it's nerve, bone, muscle in origin. And so they are going to, and again, that's usually the suffix of another, so you might see adenocarcinoma and so on. And then leukemia, right? Anytime you see the ending emia, you know, you're going to think of blood. So this is going to be white blood cells, right? Which are now in the blood in excessive amounts. And a leukemia usually starts right in your red bone marrow. So there's a stem cell in your red bone marrow that has lost the ability to control cell division. So it's just going on, going and going. So remember, that's what we're talking about here. Cancer is basically the loss of a cell and its control over cell division. Remember cell division? Remember, go all the way back to like biology and maybe anatomy, where we talked about mitosis. So basically, they've lost the ability to control that cell cycle. Okay. So again, these are some exceptions that I mentioned just before. I mentioned lymphoma or hepatoma or melanoma. Those are all exceptions to the OMA classification of benign tumors. Okay, so these are exceptions. Lymphomas are, by nature, lymphomas are usually already in more than one area because of the way that they do that and the way they spread, right? And then hepatomas are going to be in the liver, right? And melanomas are going to be the ones in the skin. All right, so question number 1, which characteristic best describes a malignant tumor, right? So are malignant tumors encapsulated, have little vascularity? What about its location? So I'm gonna let you think about that one, right? But I think you already know the answer. All right, so the malignant phenotype, right? So remember, phenotype is the expression. Okay, genotype is usually the genetic origin or the genetics of it, and then phenotype is going to be the expression of that. So, right, so again, malignant cells tend to ignore growth control signals. So we have 2 types of genes, which we're going to talk about in just a second, right? There are 2 ways really to start cancer. You have oncogenes, oncogenes are genes that are incorporated in our cells, that we receive from our parents genetically, that if turned on, can develop cancer. So we call those oncogenes. When they haven't been turned on, we call them proto-oncogenes. So for the most people who have these genes, they probably haven't been turned on. There needs to be some sort of attack on the body that causes that gene to be turned on. Remember, to turn on a gene, you have to initiate gene transcription. So there was something that was blocking it, and now because of some attack, radiation, UV light, some sort of chemical, or so on, that is now initiated. Then the other ones, which are probably the ones you've heard of more, are called tumor suppressor genes. So the tumor suppressor genes are genes that normally suppress tumors. So they're the ones that are going to control a lot of our cell cycle. So if you have a damage in your tumor suppressor gene, then you're going to have a cell cycle that is no longer in control. So when the cell cycle has no control, you're going to go, keep going and keep going and keep going. And that you're going to have mitosis and mitosis and mitosis, and thus tumor growth. Okay. So we're going to talk about this in just a second. So they have the malignant phenotype. So the expression is that you have this cell cycle continuing, right? You have mitosis again and again and again. So they proliferate without really any signals that limit the growth. They have escape signals to die and achieve a type of immortality. So they're immortal. Actually, if you look, there's actually there is a collection of cells that we do research on, scientists do research on, that are immortal tumor lines. Like, remember yesterday in the previous chapter, I believe it was chapter 4, we talked about telomeres, right? So the telomeres are the little, at the end of each chromosome, there's going to be a extra set of genetic material that keeps getting smaller and smaller and smaller and smaller, that then eventually leads to aging and slowing of the reproduction of cells. That doesn't really happen with tumor cells, right? So tumor cells don't really have that. They just keep going regardless of whether or not they are going, whether or not they have these telomeres. All right, so they lose their features. So before, they may have been, cells that secrete something. Now they lose that ability to do that, right? So they either don't do it at all or function very poorly. So those are things that you want to know, right? They proliferate without any control, right? They have this immortality where they just keep going and going and going without any basically senescence or aging limitation, and they escape. They have escape signals, right? So they can leave the tissue that they're and go and establish themselves somewhere else, and then they're differentiated. They're undifferentiated, which means they become cells that don't have any features of the cells that they were before, right? They're genetically unstable, and they also right, accumulate more mutations at a much faster rate than other cells. They invade local tissues, again, because they migrated, right? And then they basically overrun their neighbors. And then they, right, the ability to migrate is really important and colonize other sites where they don't belong. So, maybe people in your family, like I've had 2 people that are close to me, not both family, but very close friends of the family, that had breast cancer. They survived breast cancer, had their tumors removed, but yet 10 years later, they got brain cancer, and both of them at a relatively young age. One was about 65. She was an aunt. Not directly my aunt, but we're Hispanic, so we have people we call aunts that are not really our aunts. And she passed away, and then of brain cancer. And then somebody who was a very close colleague of mine, she also and my aunt was like 60, and then this colleague was 47, and they passed away, both of them, of brain cancer after having survived breast cancer. Why? Because it's the ability for these cells to just migrate and go to areas where they don't belong and establish themselves there. And then years later, they may be turned on, or they may be kind of slowly working their way in there, and you don't see it until it's something visible on an MRI. Right? So a little bit on the epidemiology of cancer, right? So cancer is the second leading cause of death. And if you look at the leading cause of death, which is heart disease and cancer, they are right there, very, very close to each other. I wouldn't doubt that one of these years, cancer is going to overtake heart disease. Heart disease is kind of, I think, maybe because of medication, we are seeing a lot less people dying. And so cancer, the more you live, the more likely it is that you're going to be exposed to something that's, toxic, that's going to cause that cancer. Some people just genetically have a predisposition to have cancer. This is not something that we can really control. And since cancer is actually your own cell doing something it's not supposed to, it has been extremely difficult in order to control cancer. It's like we can control lots of components and lots of different ways in which heart disease is going to affect a human. We have so many medications that can help with that. We just don't have the same control over cancer. It is a cell that has lost its way, and now we have to go track it down and kill it. It's very, very hard. Most cancer deaths occur in individuals over age 55. So the longer we live, the more likelihood it is that we're going to have a cancer. Like I mentioned, right? Well, men have a 1 in 2 risk of developing cancer. Women have a 1 in 3 risk. And this is going to be some numbers that you're going to look at, and you're going to see different for different cancers, right? The 5-year survival rate. So in epidemiology, and especially when it comes to cancer, we have this cutoff where if you've survived 5 years after your diagnosis of cancer, that this is called like you survived cancer. Again, this does not mean by any stretch that you're not going to get cancer after that you're not going to get a different type of cancer, that your cancer didn't spread. The reality is that things could still happen after 5 years, but we do have in epidemiology that cutoff that's called the 5-year survival rate. So if you took all cancers and you look at the 5-year survival rate, it's about 68%. This is obviously going to be different for different types of cancer. So for example, childhood leukemias are very, very survivable. We're talking over 95% survival rate. We have very good medications that target very specifically the cells that cause leukemia. They don't even have to undergo maybe some even like very dramatic chemotherapy or anything like that. You might see us improve the ability to treat leukemias in the future. So very, very, very over 95%, probably almost 99% survivable, like the childhood leukemias, which are like acute lymphocytic leukemia, ALL, is the childhood leukemia. They are going to be very, very survivable. But then when you talk about like CML, right, chronic myelocytic leukemia, you're going to have a much different survival rate. Right. So, and then again, you look at breast cancer and lung cancer and all of these, other types of cancers, and their survival rates are going to be different. It really depends on the type of cancer. All right. So if you look at male and female, right, separately, prostate cancer for males, very, very high in likelihood, as is breast cancer in females. Remember, males can get breast cancer, but they don't get it as often. Notice the other ones, right? Lung cancer is the number 2 cancer in males and females, right? Lung cancer is probably the most common of our cancers. All right, so give me just 1 second. All right, so this is A is representing the cancer cases, and B is the actual cancer deaths. Okay, so I want you to notice that's what I was looking for, because I was like, I'm not sure. Lung and bronchus cancer is going to be number one, basically in males and females. And then the second one is specific to the male, being prostate for male, breast for female. And then the third leading cause of cancer is colorectal cancer, and that's going to be the same for males and females. And then you notice the other types of cancer. So you could see here, leukemia is way down here at 3% of new cases and 4% of cancer deaths, and so on. Okay. Now, 1/3 of all cancer-related deaths is usually attributed to some lifestyle factor. So, for example, tobacco use is probably the one most important lifestyle choice that you is going to increase your chances of getting cancer, because tobacco has in it so many different toxins, and these toxic elements that you bring into your body can cause genetic changes. Again, some people may smoke their entire lives and never get cancer. That it means that they had a genetic advantage. They did not have a genetic susceptibility that caused them to have this cancer. But some people have never smoked in their lives, and they get a type of cancer that is the same as if they had smoked their entire lives. That's because they had a genetic predisposition to that particular cancer. And again, what are we going to do about genetic predispositions? There's absolutely nothing that we can do right now except monitor it. And don't smoke. Okay. Nutrition, right? So, and obesity. So what we eat and how much of it we eat can also really affect the ability for cells to grow. Sun exposure, it's critical, right? Skin cancer, especially in people who are very susceptible to skin cancer, which is the lighter your skin, the more likely it is that you are at higher risk, right? You're at higher risk for skin cancer, because people with a lot of melanin, right, are going to have protection against the sunlight, because their ancestors, right, were from an area of the world that had a significant amount of exposure to the sun. So people whose ancestors live closer to the equator are going to have more pigment, right? So because they needed that extra protection. So if your ancestors are from Norway or Finland, and you're now living, in Brazil, right at the equator, you are going to be at a genetic disadvantage because your ancestors weren't from there. So you have no protection against that type of sun exposure. So you need to cover. Okay, early screening and early detection. That's basically the only thing we can do. We can't stop you from getting cancer. We can only detect it early, and the earlier we can detect it, the more likely it is that we are able to treat it and to have a successful outcome. What type of prevention is that? Early screening. First, right? Primary, secondary, or tertiary prevention? Let me think. Secondary prevention. Very good. All right. So again, tobacco use being probably the most important one, right? If you look at this, let me see if it's the next slide. This one. It kind of blows my mind, being that I studied epidemiology. When you notice the lung and bronchus cancer increase, if you look at behaviorally, when tobacco use became very common in the United States, remember these are all United States numbers, right? They became very common after prohibition, right? So prohibition, right, in the 1920s, when they prohibited alcohol, a lot of people turned to tobacco to kind of replace that need that they had for something to make them feel good, right? So that wasn't about the 1920s, 1930s. And I want you to notice that the increase in cancer, significant increase in cancer, came about 30 years later. For females, it was not the same time. For females, the time in which we started to really see an increase in tobacco use among women was around the time when women replaced a lot of males that had, obligations to World War II. So a lot of women took over the jobs of men in, World War II. They started smoking around that time. That's kind of when it became a little bit culturally and, society wise. That's when we started, as a United States, started using tobacco, and females started smoking. That was around the 1940s. And I want you to see that the increase came about 1980. So 40s and 50s, and then about 40 years later is when you start to see an increase in the lung and bronchus cancer. So these things don't happen right away. It's not like you start smoking and you get cancer. So you smoke and smoke and smoke and smoke and smoke. You're like, oh, nothing's happened to me. Smoke and smoke and smoke and smoke. Oh, and then 30 years later, you're going to get something. Now, if you stop smoking, just like we talked about last time, your cells can fix themselves and start to return back to normal. So you have to really do that and quit. That's the bottom line. I want everybody in our class to quit smoking. All right. So tobacco, right? Lung cancer is the leading cause of death in men and women and has a terrible survival rate. Also linked to pancreatic, kidney, bladder, mouth, esophageal, and cervical cancers. Particularly if you're chewing tobacco, you'll see mouth, esophageal, and even pharyngeal cancers, or people have had to have their tongues removed, parts of their cheeks removed. Unnecessary. Absolutely unnecessary. Stop smoking now. Okay, 2 types of carcinogens, right? With the initiator, which causes some genetic damage. The genetic damage is then going to either stop the tumor suppressor gene, or if you have a genetic predisposition to a oncogene, it will turn the oncogene on. All right, so tumor suppressors, you have to turn them off so they no longer suppress tumors. Oncogenes, you turn them on. Okay, and then you have a promoter, which promotes tumor growth, again, if you turn off the tumor suppressor gene. So you have a genetic damage to one of those 2 things, and then you have tumor growth. So then tobacco smoke contains both types of carcinogens. Secondhand smoke also increases risk for lung cancer. You can see that. I want you to also notice one thing that a lot of people maybe don't notice. It's actually more dramatic if you go back before 1930. Stomach cancer right here is the #1 cancer in 1930. But stomach cancer, which is due to all of the preservatives that are chemicals, right, in our food. I want you to notice that there was this sharp decline in stomach cancers. We do not, and now on this chart is actually the lowest, and this one as well. Reason why is because we used a lot of preservatives in our food before, because we didn't have refrigeration. But I want you to notice around, 45, 50, 60s, right, when we started getting refrigeration, stomach cancers started to decline. So we had better ways of preserving meat, especially, and so no longer stomach cancers. So when people tell you, oh, things that you eat can cause cancer, I'm like, well, I want you to take that with a grain of salt, because stomach cancers, being where your food goes when you eat it, is probably one of the least seen cancers in this country. You'll see that a lot of Japanese and people of Asian descent are going to have a significantly higher stomach cancer rate or risk. All right, so you can see here, tobacco use statistics, right? So attributable to smoking, all of this, and then other causes. This does not mean that because you are non-smoker does not mean you're not going to get lung cancer. Again, you could possess that oncogene, and just some exposure to something that you are breathing in your atmosphere in which you live. Maybe you work in a factory that has a particular toxin that runs in because of the process needed to make the whatever you make in your factory. You're going to have an exposure to a chemical that then is going to cause you to have cancer, right? Just as asbestos, right? People who work with asbestos for so many years now have mesothelioma, right? Mesothelioma is basically the lining, right? Asbestos gets stuck in the lining of the pleura, and then you're going to have some difficulties with the expansion and retraction of your lungs. Same thing with coal mine workers, okay? Or other miners. Lots of very stale air, and air that is going to have lots of toxins in it. So that's very bad, right? So dietary fibers believed to be related to cancer risk. So fat, a lot of things that are fat soluble can kind of hide in fat, right? Fiber, especially with colorectal cancer, if you have a predisposition to polyps in your family, having a good amount of fiber in your diet might help you kind of reduce that risk. Again, cancer has to do with the genetic predisposition. So I can't help you if I don't know your genetic predisposition to these things, which I don't know if you've seen, there's different tests now that do tell you your genetic predisposition to even colorectal cancer, right? Alcohol, right? Obviously dietary, and does not need to be consumed and can also be very toxic, and then antioxidants as well, right? So limit excessive calorie and alcohol intake, right? And then obviously increasing dietary fiber and fruits and vegetables, particularly those fruits and vegetables that don't have, pesticides, because pesticides obviously can also increase genetic modification, right? Because some of them are carcinogenic. All right. Our carcinogen is something that is potentially cancer causing. So you'll see that there are a significant amount of carcinogens in tobacco smoke, but that's not the only thing. Anything that is a chemical that is not something that's in our body can potentially be a carcinogen. So you have to think about many things that even in excess, things that are in our body in excess could be carcinogenic. All right. So proto-oncogenes, right? Again, these are oncogenes, which are genes that are in our genetics that then can get turned on. So these are proto, meaning that they're not turned on, but if they do get turned on, they become oncogenes, which then, right, are going to induce those pathways that are going to start the cell division. And then the tumor suppressor gene, right, inhibits the cell cycle, right? So if you turn off the tumor suppressor gene, you are not suppressing the cell cycle. So the cell cycle just keeps going and going and going. You get more mitosis, more mitosis, more mitosis. You get more and more cells, right? So cancers may arise when tumor suppressor gene function is lost or abnormal. All right. So again, proto-oncogenes, just like I mentioned before, a gain of function mutation, right? So again, when you mutate the proto-oncogene and turn it into an oncogene, then you're making something that you weren't making before, something that makes a growth factor so you have a cell now that is going to start growing because you have the growth factor or the receptor, right? You initiate a new receptor to be made, cytoplasmic signaling molecules or other transcription factors that are going to initiate or gain of function mutations. Right, so you can see here abnormal growth of a particular growth factor makes this gene make product, okay, or growth factor receptors, and so on. All right, so growth factors, right? So little peptides that are secreted into extracellular space and diffused to nearby cells. They can interact with other receptors on target cells and activate a cascade. Right? And it could even autocrine cascade, which means it's stimulating itself. Right? Then also transmembrane proteins and basically mitogenic, right? So they cause mitosis or enzymatic, and they activate cell proliferation. Right? So expressions of things like receptors can be as a response to these mutations. You can have an increase in translation, transcription and translation. So making of a protein that's going to express a receptor, because remember, receptors are proteins that should not be there at all, or an excessive amount of something that should be there, or something, a type of receptor with a change in it that makes it much more likely to bind something. Right. So for example, one of our mutant proto-oncogenes, right, is called the RAS gene. The mutations can lead to cancer. Right. Another one that can be, right. So if you have assembly, right, an assembly of proteins, right, to begin gene transcription, right. So normally they may not have any function, but mutations can cause an overproduction of these transcription factors. So for example, the MYC gene. So if you look at the MYC gene and the RAS gene, let me see if they have in here. I'll go back to it. So the MYC gene and the RAS gene are actually, there's a little picture of it and a little picture of a rat. And so what we've done is we've done actually like experiments where we put the RAS gene into a rat, and it's actually on figure 712. It's probably in this presentation somewhere on page 127. And so you see the RAS gene does not cause a cancer in and of itself when introduced into the rat. The MYC gene does not have any cancer, but when you have both of them together, they are synergistic and they actually do cause tumor. So so these are an oncogene, right? And then overproduction of transcription factors. That's the MYC gene, right? And then proto-oncogenes, they become activated oncogenes when mutations alter their activity, right? So oncogenes can also be introduced to a host by a retrovirus. So retroviruses, I want you to remember what retroviruses are. Retrovirus is an introduction of a genetic material, but then the genetic material is usually in the form of RNA, but then the RNA gets made into a DNA by going backwards, right? Retro meaning backwards. And then that DNA can get incorporated into your genetic. So that we basically, that's how the retrovirus survives, by introducing itself into your genes and making more of itself. Right, so the DNA sequence may be lost, right? Depending on where it's introduced, and allow then the proto-oncogene to become abnormally active. So that maybe that DNA sequence that was normally making something else, it's going to interrupt that, but it's going to continue transcription. But now within it, that original, you have a oncogene that has been introduced. So now you're making the oncogene, and that transcription is going to lead to an overproduction of whatever the oncogene had, because whatever the original DNA sequence is now been disrupted, so it's not going to be able to make it in the same order that it had before, right? So chromosome replication can also cause extra copies of proto-oncogenes in the genome. So you can see here inserted viral oncogenes, right? Mutation, some sort of mutagenic event. A mutagenic event, again, could be radiation, it could be UV light, or some other type of carcinogen, right? And then activates the proto-oncogene, and then there's amplification of that proto-oncogene by making more copies of the oncogene that are then inserted into your DNA. I want you to remember that one thing, right? When you have this happen, I want you to notice this is within one cell. Okay, so this is all happening within one cell. So say your skin cell, right? A mutagenic event, UV light goes in and causes that damage, turns on a proto-oncogene, you get melanoma. But that's a somatic cell. So you have a somatic cell as a cell of your body. So you're going to have that happen in one part of your body. This is not something that you're going to transmit to your children because it's not in your egg cells. Okay. However, something that you genetically, a predisposition that you got from your parents for a particular cancer, and you have that genetic predisposition, you can pass that genetic predisposition off to your children. So in order for you to pass down a particular, you have had to have it in your DNA when you were born so that it replicates with every single replication of your chromosomes. Right? So you're not going to get like skin cancer and somehow that skin cancer is going to get passed down to your children. The predisposition for skin cancer will get passed down, but not the skin cancer you get when you're already 34 years old and you get it on your skin. No. Okay? It's really important because some people don't quite understand that. Remember, you have germ cells, right? Which are those cells that are your egg or sperm cells. Those are the ones you're going to make babies. So if you have something that's damaged those cells, yes, is that possible? Absolutely, it's possible. But you have to damage those in order for you to be able to pass down a genetic predisposition. Right? You get a cancer on your skin, you're not going to pass that down. Okay. So retroviruses like HIV actually make you very susceptible to a type of sarcoma called Kaposi's sarcoma. Right? The Epstein-Barr virus can also make you predisposed to something called Burkitt's lymphoma. And then the human T lymphocyte virus type 1 can also give you T cell leukemia or lymphoma. So these are all retroviruses that insert oncogenes. All right, composed of RNA. They have this enzyme called reverse transcriptase, which makes the DNA from RNA. So you have RNA, you have reverse transcriptase, and you make DNA. Okay, so I don't know if you remember, but obviously HIV being the major retrovirus that has been kind of plaguing us for the last 30 years or so, 40 years. Remember that it has reverse transcriptase, and we have medications that stop. AZT is the medication that stops or blocks reverse transcriptase. Does that block HIV from producing? No, because viruses replicate in many different ways. This is why we have cocktails of medications to treat HIV, because viruses, they will find a way to replicate, even if you block reverse transcriptase. All right, so reverse transcriptase is what retroviruses use in order to incorporate that DNA into your genes. Okay, so tumor suppressor genes, right? So contribute to cancer only when they've been turned off or are not present. Okay, so both copies of tumor suppressor genes have to be inactivated when cancer develops, because if you have one, at least you are suppressing some, right? And then one can inherit a defective copy of tumor suppressor genes, right? And then if you do, you are at much higher risk of developing cancer. All right, so mutations can cause the gene not to function. So the tumor suppressor gene does not function, then the tumor suppressor is going to turn off, right, that ability. Right, it's going to turn off that ability for you to stop cell division. All right, so you'll see chromosome deletions, point mutations, and non-disjunctions that are going to contribute to that. And then sometimes an epigenetic process kind of also outside of your gene can stop gene expression. It does not necessarily require a mutation. All right, so they can also silence that gene. All right, so the retinoblastoma gene, right, is a cell cycle, a master break for the cell cycle, right? So that's the RB gene, and the RB gene normally stops cell division, right? And so anytime that you stop the RB gene from working, you're going to stop that block that it has against cell division. So cell division then goes crazy and you have a tumor. Okay, so in inactivating mutation of the RB gene removes the restraint on cell division, and cell division just occurs. So some cancers, it is called the retinoblastoma gene, so it does cause retinoblastoma in some, but also other cancers, you're going to see that the defective RB gene might be the cause for it. Okay, so you can see here a little on how it works. Okay, don't worry too much about the specifics. Just know that cyclins and CDKs are going to be components that stop the cell cycle from going crazy. Okay, so that's why they're called tumor suppressor genes. And the P53 is probably the most common tumor suppressor gene. And it basically is more than half of all of types of human tumors lack a functional P53. You could be born without a functional P53. It's possible. And you will have cancer in some of these babies, even when they're born. They will already have cancer. It's called Lu-Framani syndrome if you have 2 defective P53 genes. Is it possible? Yes, it is possible. Okay. It's unfortunate, but it is possible that 2 people that both are carriers now give their child both defective versions of the gene. All right. So, right. So what does P53 normally do? Right. It inhibits cell cycling. So it accumulates only after cellular DNA damage. Right. And so binds to damaged DNA, stalls division to allow DNA to repair itself. And it also directs cells towards apoptosis. So P53 gene is basically going to do that. Now, if you have an abnormal, right, P53, then any one of these things are not going to be able to occur, right? So you're not going to have, the CDK inhibitor, and so the normal cells can't repair themselves. A cell that's defective won't be able to go into apoptosis, right? And then so anytime of these, ionizing radiation, carcinogens, or mutagens that cause a loss of P53, then is going to result in malignant tumor cells that weren't able to undergo this repair, or if they can't repair it, apoptosis, so that they die. So you want to have your cells either repair themselves or die before they cause a tumor. But again, P53 is damaged, it can't do that, then you're going to get a tumor. All right, so genetically damaged or unstable cells to survive and continue to replicate. Right, so chemotherapy and radiation often damages target cells and cancer cells and trigger P53 mediated cell death. That's usually how chemotherapy and radiation work. All right, so cancer cells that lack a functional P53 may be resistant to chemotherapy and or radiation. All right, so now I'm sure you've heard of BRCA1 and BRCA2 genes. They're associated with breast cancer. They are also tumor suppressor genes. So people with a history of and inherit the BRCA1 gene are very much at risk for having breast cancer, because they will not have that tumor suppressor gene. So in other words, you get two genes, one from your mother and one from your father. So if you get one damaged one from your father, let's say, right, and you have one normal one from your mother, now you only have one BRCA gene that's working. If for whatever reason that BRCA gene breaks down, right, you don't have a backup. So now you're going to have breast cancer. It's possible that you receive damaged BRCA genes from both of your parents, and that is really going to be at a very high risk of getting breast cancer. All right, so carcinogenesis, right? So, right, genesis, creation of, carcino, which is going to be cancer. Initiation, promotion, and progression. So, right, what is initiation? Some sort of DNA damage, some mutation. Promotion is going to be proliferation, growth, right? And then progression is into a more cancerous or malignant phenotype. And that's going to be the progression. So what initiates it? Genetic mutations initiate it, right? So inactivated tumor suppressor genes, or a proto-oncogene that now has been turned on or added, right? So then proliferation is obviously going to be, cell division. So we're going to have lots of cell division. And then obviously not every single cancer is going to be exactly the same, right? They all have a little combination of mutations that can lead to malignancy, right? So initiation. So you have to complete, right, carcinogens. So complete carcinogens can do it, initiate cell damage all on their own. Sometimes there are partial carcinogens that need something else to be attached to it to stimulate that growth, and usually require something else in order to initiate cancer. So they're not really capable of doing the genetic mutation themselves. So they need something to be added to it. Okay, promotion, right? Cell proliferation. So activated of another oncogene or inactivation tumor suppressor gene, nutritional factors, right? So lots of nutrients in excess, right? That infection can also, remember, insert an oncogene like HIV, right? So regulated, right? So promotion is regulated by hormones, right? So if you have hormones that are being produced in excess, then they can also stimulate. So remember when I a little bit ago, I talked about some cancers that we as researchers have and they're immortal. One of those cancers is a HER2 cancer that we have a immortal cell line that these cells just keep dividing and dividing, and we could use these cells that keep dividing and dividing and dividing. They kind of like, they grow them, and then they just kind of like send them to researchers throughout the world so that they can try different things for them, right? Well, one of the things that the HER2 gene does is that it introduces estrogen receptors. So if you have an estrogen receptor that has been initiated, but you don't have a surge of estrogen, then you may not get cancer. However, let's say that you were undergoing your normal menopause, but I gave you hormone replacement therapy, which involves estrogen, and I don't give you progesterone because I just given you estrogen. What do you think is going to happen, right? So you have an estrogen receptor that now is receiving estrogen more than it should, because remember, it was kind of turning itself off. All of a sudden you increase the amount of estrogen that was available, and so you upregulate this estrogen receptor, that may be cancerous. And so all of this extra estrogen is now going to cause you to have initiation of cancer. Do we know when those things happen and who's genetically predisposed? We don't know that. And that's the problem. We don't know that. We only know from family history. Can we take a genetic test? Absolutely. But remember, I want you to understand that the human genome wasn't all figured out until very recently, right? Till about 2005, 2006 is when we sequenced the entire human genome. So now we have, that's why we have all of these genetic tests that are coming available, because now we have a much better understanding of what genes lead to what. So we are kind of in a really cool place in science, because we have all of this to look forward to in this century, sort of figuring out how to prevent genetic disorders, because we weren't able to do that before because we didn't know the genes. We knew that genes were present in certain humans because of genetic predisposition, right? Because we knew that if your mother had breast cancer and your grandmother had breast cancer and your aunt had breast cancer, that you were at a higher likelihood to have breast cancer. It was just obvious. But now we know the gene behind that. And so again, maybe if we know the gene in the future, we'll be able to give you a genetic test and we'll know that. And so we'll monitor you from the beginning for breast cancer, from the time that you're 12 or you're 20, because now we know that you're already at a genetic predisposition for that. That's why some people who are BRCA positive have double mastectomies, even though, like, they know my grandmother had cancer, my mother had cancer, my aunts all had cancer, so I'm just going to have this removed. And some insurance are even paying for these things, okay? All right, so cancer cells produce, right, telomerase. Remember the telomeres that I told you, right? So they break down the telomeres, and it allows immortality in cancer cells. All right, so progression, right? They begin to exhibit this malignant behavior. And then these tumor cells, right? They're going to start to become very different from the normal tissue. And then, so that phenotypes gives them, this major advantage to proliferate more readily. All right, so some of the progression to malignant characteristics includes laminin receptors, lytic enzymes, right? Anchorage independent. So anchorage is like, remember how tissues all anchor themselves together? If you make a cell that now starts to break apart the anchorage between all of the tissues, remember desmosomes and like tight junctions. So all of the links between the cells are broken. So now these cells sort of migrate, and they migrate into your lymphatic system and then kind of go throughout your body. Right? And then the bizarre karyotype, right? So you can see some of the cancer karyotypes. So you could see this one right here has a particular addition that may have been lost right here. Okay, so I know that those kind of look a little cray-cray, but what it is so this one has a duplication in it, right? And that is going to cause this to become genetically modified. All right, so place the multi-step nature of carcinogenesis in order. What occurs first? I'm going to let you think about it. What's your best guess? All right, so you probably know that metastasis is probably the last step. So then that might have led you to think, A and D. But then I want you to really think progression is a word that means sort of the same thing. So then that sort of brings into, right, play A and B. You can either, it's tumor suppressor gene or an oncogene. So these two things are wrong, because you don't have to have necessarily this one. It could be one or the other. So then you want to just say initiation, promotion, and progression, because those are vague enough for you to know that this is the correct order of how things are going to happen, but it's not being specific, because it doesn't always involve these genes, because it can involve BRCA. Doesn't always involve a tumor suppressor gene, because you can have an oncogene like the HER2 gene, right? And it doesn't always just involve a proto-oncogene and an oncogene, because again, you can have BRCA and RB and P53, which are other genes that are tumor suppressor genes. All right, so metastasis, right? Cancer cells escape their tissue of origin and maybe colonize in another area and start replicating at a new site, right? So how does that happen? Remember that anchorage that I told you about? So they become like the anchors are going to break apart, and basically they are going to be able to become more mobile, okay? So you can see there, loosening of intracellular junctions, degradation, right? Attachment, and then migration. All right, so then, right, they can spread via either the circulatory or most likely the lymphatic systems. This is why we check the lymphatic system most of the times, our lymph nodes near where the tumor is, to see if there has been any sign of spreading, right? And so tumor markers help identify parent tissue cells of origin. So what might you do? So let's say you do a biopsy and then you detect a particular modification in the cells. You might be able to test the cells for certain genes. So you might find a gene in there. So then let me go find that same gene in my tumor, in my lymphatic system, in my lymph nodes, if that is present in there, right? Right. So it could be released into circulation, into the circulatory system, also through the blood as well. Right. So tumor markers help identify parent tissue of the original origin. Right, and then so you can track some type of tumor activity. So you might have a increase in a particular type of whatever it is that tumor is secreting. Angiogenesis, which I mentioned already, right? Triggers are not necessarily understood on how this happens, but when tissues require more blood vessels to grow, blood vessels grow. So if we knew the trigger of how that happened, then we might be able to stop it at that level. But we don't exactly know what triggers angiogenesis, right? So inhibition of angiogenesis is an important therapeutic tool, right? So, I mean, really, this is a really easy question, obviously. Okay, grading and staging of tumors, right? We're not going to be grading tumors, probably not going to be your job as a nurse, but it is good to understand the grading of tumors, right? So you're probably not going to be giving the diagnosis. You're probably just going to be reading about the diagnosis in a patient chart, for example, right? So it's a good idea to understand where they may be coming from, because you have the characterization of the tumor cell, the degree of anaplasia, remember, or change of the particular cells that are growing. Right? You might see increases in classes of malignancy, and then the greater degree of anaplasia, the greater degree of malignant potential. All right, so staging, right? Location, tumor size, extent of local growth, you might see lymph node involvement, and distant metastasis. So the most common system is called the TNM system, in TNM standing for tumor, nodes involved, and metastasis. Right, so that's going to be rather important for you to kind of get the TNM system, right? Early stages are usually very asymptomatic. So this is why oftentimes, especially for like ovarian cancer is very asymptomatic. So or pancreatic cancer. So people don't really know that they have ovarian or pancreatic cancer till they're almost stage 4. And so that's why they become an increase in likelihood of dying of this particular type of cancer, because most people have no clue that they even have them, right? So that's why genetics and a genetic, a test that might be able to tell us whether these people are susceptible might be a really good idea. All right, so some warning signs of cancer, right? Change in bowel or bladder habits, right? A sore that doesn't heal, unusual bleeding, thickening or a lump in the breast or elsewhere, indigestion or difficulty swallowing, an obvious change in a wart or a mole, right? Nagging cough or hoarseness. Those are all the caution signs of cancer. Right, so pain, right? Obviously very non-specific, right? A common and feared complication of it maybe could be seen in metastasis or tissue destruction. Could also be caused by cancer treatment. All right, cachexia, right? An overall weight loss, general weakness. So you might see a loss of appetite and anorexia, increased metabolic rate. Remember, angiogenesis in and of itself can cause cachexia. You'll see definitely weight loss because of the increase in nutritional requirements of tumors. Right, so you can see that cachexia. Right, so bone marrow suppression contributes to anemia, leukopenia, and thrombocytopenia. Anemia is, right, a decrease in in circulating red blood cells, right, and so that bone marrow cells might be attacked. So you might see bone marrow suppression, and thus, and especially in chemotherapy, you might see a decrease in the ability for those white cells to respond. So you're going to see a lot of increase in right, opportunistic infections and so on. Right, so you're going to see infections, and like, so for example, like HIV, right? HIV, because it targets the immune system, most of the people that die of HIV are going to be dying because their immune system was affected. Yes, so they're dying of opportunistic infections that other people just don't get because our immune system is fine. Right, so that could happen also in cancer, right? Because people get a lot of infections because of that leukopenia. So leuko meaning white, penia meaning low, okay? So deficiency in circulating white blood cells, right? Could be malignant invasion of bone marrow, or malnutrition or chemotherapy. Both can lead to that, right? And so obviously infections become a much greater threat to the individual. So you're constantly trying to prevent infections, right? So even chemotherapy might be, has to be eliminated or even pushed back because the white blood cell count might be too low. Thrombocytopenia, so platelets are low, right? So when platelets are low, then obviously you're going to have difficulty clotting blood, and that's going to be a major important thing, right? If your count is below 20,000 cells, you're going to see that they're going to that you're going to have a significant difficulty clotting blood. So anemia, leukopenia, and thrombocytopenia all can be managed by replacing those from you know, a blood transfusion. Other effects that you might see, you're going to see hair loss and mucosal membranes that are being sloughed, right? So that also causes a lot of pain, and obviously hair loss is, it could be very personal to somebody to have hair, and that's part of their personality, part of who they are. And so that could be very, you know, it can affect somebody, because if you look in the mirror and you see somebody who has lost hair, it's not the person that you used to identify with, and so you become depressed. And so depression doesn't help your body heal. And then, you know, so it could be a complication of obviously chemotherapy and radiation, right? Other effects, paraneoplastic syndromes, where you have tumor production of other hormones or cytokines, like causing Cushing syndrome after, you know, secondary to ACTH secretion. You might see hyponatremia. So these are paraneoplastic, which means sometimes these are, you know, people don't know that you have cancer, but you have some of these, what we call paraneoplastic syndromes, hypercalcemia, hyponatremia. We're like, wait a minute, what can be going on? And then we start to look for, like, there's a cancer somewhere. So paraneoplastic syndromes can lead to a cancer diagnosis that maybe you didn't know of, right? So cancer therapy, right? Early detection is the best prognosis for cure. The earlier that we can find this, the better, right? Surgery, radiation, drugs, or chemotherapy, right? And so we have immunotherapy. So if you see a lot of new medications that end in the letters MAB, MAB, right? Those are monoclonal antibodies that are basically going to attack specific antigens on the surface of our cells. So those are very targeted therapies. And you might see stem cell transplantation. That one's a little bit more controversial, right? So surgery, if you have a solid tumor, let's remove it, right? If it's possible. Sometimes it's not possible. Sometimes people have brain tumors and they're inoperable because you can't separate the brain tissue, the good brain tissue, from the bad brain tissue to get to the tumor. This is impossible. Right, so often, you know, accompanied by radiation therapy or chemotherapy. And I want you to understand that for brain cancer, you can't give chemotherapy, because if you remember the blood-brain barrier, all these toxic chemicals of chemotherapy that are meant to go in and kill cells are not going to be able to do that. They're not going to cross the blood-brain barrier. So brain cancer is going to be limited by the kind of chemotherapy that they can, only those chemicals that can cross the blood-brain barrier are going to be able to be used. And so most of brain cancers can only be targeted by radiation therapy, right? So kills tumor cells by damaging their nuclear DNA, right? Sometimes, right, may or may not kill the cells directly, but can initiate apoptosis. And that's what we often are going to see, right? So small doses of radiation are usually the way we do it. Sometimes targeted radiation. And then so some normal cells can be killed as well during radiation therapy. That's obvious, right? So drug therapy, administering some anti-cancer chemicals like tamoxifen for those estrogen receptors, right? Most are cytotoxic, non-selective for tumor cells, right? So you can see other drug therapies as well. Often will have bone marrow suppression as a side effect. And so you will have opportunistic infections, okay? So some approaches, again, by inhibiting angiogenesis, right? Or anti-angiogenic drugs. By, taking away their nutrition supply, you can start to decrease the size of the tumor. Immunotherapy, right? Interferons, right? That they're going to, produced by immune cells. The interferons can basically interfere, right? Kind of as their name, right? Is, right? To initiate the immune system. Interleukins as well, right? Monoclonal antibodies. These are the ones that we're looking at now. So many drugs, if you look at them, they say MAB at the end. So those are monoclonal antibodies. Right. So usually you'll see them in addition to surgery, radiation, or chemotherapy, rarely by themselves. Right. So you could see some of the MABs here, okay, that are being used. The NIBs are going to be blocking tyrosine kinase, which is going to actually also cause a cascade of growth throughout the body. They're like G protein coupled receptors. Remember the secondary as an intracellular, right, second messenger, and that activates some tyrosine kinases, and you don't want to activate tyrosine kinases if you already have a cell cycle that is not controlled, right? And then so suppress overactive oncogenes, right? And so replenish tumor suppressor function. So those are kind of the targets that we're trying to do here, right? So some gene and molecular therapies, right? Genetic alteration of tumor cells to make them more susceptible, or, to make them more efficient killers of tumor cells. These are things that are going to be difficult to do. So genetically altering anything is going to be very, very difficult. It is proven to be very difficult, but that's the future. The future is us understanding genetics, us knowing the human genome, and us knowing where to look, and then trying to do something about it. That's the 21st century right there. 21st century medicine involves genes, right? So they can be directed. And then stem cell transplantation, especially in life-threatening disorders, which of like bone marrow and so on. So you might see stem cell transplantation for that. So for example, bone marrow function is going to be eliminated in those like leukemias, and so you irradiate them, and then now you give a stem cell transplantation or bone marrow transplant, right, to replace the cells that you've lost. All right, so you need a donor. That donor needs to be tissue matched. You will see that the donors are they're going to look at their HLA genes, and the HLA genes are basically your tissue match. And if you have HLA genes and there's 6 of them, you need to match at least 5, if not 6, in order to get a suitable donor, right? So parents are usually not going to be good because you are a mixture of your mother and your father genetically. So you're not going to be identical to your mother or your father. So siblings are better chance of matching because they are also receiving part from their mother and part from their father. So you could be receiving the same part from your mother and from your father. If you don't have somebody among the family, the immediate family really, right, that matches, then looking for somebody that matches your tissue type throughout the United States, for example, could be very difficult to find.